My name is Emily Fox, and our group's presentation will be on the spinal cord injury of a C5 complete injury. For the background information, the primary muscles of C5 are the rhomboids, deltoids, biceps, rotator cuff muscles, the brachialis, and the brachioradialis. And then the movements are shoulder abduction and rotation, and then elbow flexion. For the physical symptoms of this injury, typically results in paralysis of both sensory and motor in upper and lower body. They may be able to raise their arms up and bend their elbows. They have normal head and neck control. Spinal shock can occur following the injury. There is also high tone in bladder and bowel muscles. Generally, these individuals do not need assistance with respiration, but breathing may be weak. And then autonomic dysreflexia can occur. For the cognitive symptoms, there is no sensation or control over movements below the injury. There is a risk of suffering cognitive impairment and greater. The risk of suffering cognitive impairments is greater in individuals who suffer a spinal cord injury than those who do not. There's a decreased awareness of abilities post-injury, and there can be impairments in attention, concentration, memory, problem solving, and reasoning. There are significant individual differences in cognitive functioning after spinal cord injuries, and there is a wide range in performance depending on the severity and pattern of the affected area. For the emotional aspect of this injury, the client may not be ready to make decisions or participate in therapy. Spinal cord injuries can result in a change of relationships and support systems, and they can also lead to self-esteem issues as client grows in understanding of their disability. There is the decreased independence may be emotionally taxing on the individual, and the client may also experience increased depression, stress, and or anxiety following their injury. I am now going to pass it on to Alex.
Okay, so I did assessments. The first assessment is called the American Spinal Injury Association, known as the ASIA exam. It's performed within 72 hours of a spinal cord injury or after spinal shock has resided. This standardized test will test strength and sensation, so you can learn which parts of the body are functioning normally and which are not. It classifies the level of the spinal cord injury and predicts recovery from the spinal cord injury. In the ASIA exam, it's comprised of a motor exam, a sensory exam, which consists of light touch and pinprick, and then an anal exam. The anal exam is a vital last step because this tests the ability to voluntarily contract the anal muscle, so you can determine if it's complete, incomplete. But yeah, and OTs can perform the ASIA exam. They just have to get certified in it. Our next one would be range of motion and muscle strength. These two tests give information on the freedom of a joint moved in a certain direction, strength and function of the upper extremities impacted by a C5 complete spinal cord injury. In a spinal cord injury, the loss of joint range of motion, movement, and joint mobility is a common complication. Range of motion, you can measure it passively, active assisted, or actively. And then manual muscle testing is assessed in the early acute phase following a spinal cord injury. For both measurements, we would want to look at elbow flexion, shoulder abduction, external rotation, and it's important to consider making sure the scapula is well supported throughout those motions. The Jepson-Taylor hand function test is an upper limb and hand function standardized and objective measure of fine and gross motor hand function using stimulated ADLs. Time required is 15 to 45 minutes to complete. Since we know in a C5 they don't really have much wrist flexion extension, we would be really looking at upper limb. There's 7 subtests, so there's riding, simulated page turning, lifting small objects, simulated feeding, stacking, and lifting large, lightweight, and heavy objects. Then finally would be the spinal cord independence measure. We know it as the SCIM. It takes approximately 30 to 45 minutes to administer and score. There's 19 items, 3 domains assessed. It's a 0 to 100 score scale, 0 meaning total dependence and 100 meaning complete independence. In the SCIM, it addresses 3 specific areas of function: self-care, which can be feeding, grooming, bathing, and dressing; respiration and sphincter management, as well as the use of a toilet; mobility, bed mobility, transfers, and mobility in indoor and outdoor environments. I will now pass it off to Tyler to talk about interventions.
My name is Tyler Walkinshaw, and I'll be going over the interventions for the C5 complete spinal cord. The first possible intervention is universal cuff for self-feeding. Through this, the patient may learn education through using the elbow flexion and shoulder abduction to bring food from the plate and into mouth. It also helps with activities of daily living or ADLs, promoting independence through the self-feeding and eating. And lastly, socialization. This gives the patient more capability to engage in the socialization of eating rather than later of having caretaker feed patient, where there's typically associated negative connotation of minuscule independence of feeding, mostly towards that the patient might feel. And the benefits of this universal cuff for self-feeding are, like mentioned previously, the increased independence and increased social engagement. Another intervention would be the bowel and bladder and the education here, and the importance of this bowel and bladder management for the client and the caregiver. And this eliminates the risk of autonomic dysreflexia, importance, and emphasizes the importance of hygiene when performing these tasks for reducing the chance of getting a UTI. And another way we could go about this would be to create a home exercise program that explains the process of a rectal suppository. And lastly, education on this can aid in the process. And suppository with the universal cuff can be performed in electric leg emptier suprapubic catheter for the bladder, and those would be our methods to complete this. Lastly, another intervention would be the power wheelchair with the joystick control. This would obviously be a little bit further down the road in the rehab journey. And we'd practice using transfer board to get into the wheelchair, especially at first, where we'd educate them. And this would be to ensure the safety of the client and understand the caregiver will give assistance when needed. Education and training on the using of the power wheelchair, furthermore, would be the client and the caregiver a full understanding of what the chair can do and can't do and the functions of that joystick that they will be able to use. And the benefits of this power wheelchair and joystick increases the independence, just like the last few, in everyday life and mobility around the community and overall the activities of daily living and the engagement that they'll now be able to participate in. If you have any questions, you can contact us, and here is Emily, myself, and Alex's emails. And lastly, these are the references for our PowerPoint, and thank you very much.